You're listening to the Foreign and International Medical Graduate Show, a podcast to inspire physicians in the process of immigration to the United States and access to graduate medical education. We create meaningful and helpful content that motivates medical students and doctors throughout the world, with the goal of creating a community that supports itself and gives feedback to each other, that stays updated with the most recent tips and advice on how to make it in America and become a successful resident or fellow in the speciality of your dreams. Dr. Alonso Osorio is board certified and residency trained in both emergency and family medicine and will be bringing you 20 years of his personal experiences, struggles, and motivation. We'll be chatting with people like you to talk about the lessons they've learned along their personal path, how to make an impact, and how we can all benefit from it. Also, we'll analyse the current resources available and how to benefit from them. Thanks for joining us. Please enjoy the show.
Hello, superstars, and welcome to episode number 24 from the Foreign and International Medical Graduate Podcast. This is your host, Dr. Alonso Osorio. And tonight I have a personal friend of mine and fellow Colombian as well, who has been in this country for a very long time, and that's why he doesn't have an accent like I do. His name is Miguel Cerveleon. He's a fantastic respiratory therapist that I've been working with in the emergency department for the last 5 years since I joined my current practicing group. And I always think I had a great relationship with my therapists throughout my life because I have learned so much from them. Miguel and I have been exchanging messages for the last few days in Messenger. And we were remarkably interested to get the message to the community, to the world, to our people of how essential and how fundamental are right now. They always have been. Our job cannot be done without them. They're an essential part of the healthcare system. And this is the moment that we cannot forget them. This is the moment that we have to remember that they're a fundamental part of the whole active mechanism on how we're providing medical care in the United States and across the world. And at this moment, they're critical, and I don't think they're getting the enough recognition that they actually deserve for the work that they do. So I'm extremely excited to have you here to talk about this topic, Miguel. And first of all, before I keep going on and on and on, tell me more about yourself and what do you exactly do these days?
Yeah, thank you, Dr. Osorio. It's always been a pleasure to be able to work with you, obviously in those critical times, as you already have described most of them. I think that we partner in a lot of those critical moments in our facilities and things like that. So I'll just thank you for that. I think that a lot of people just are not aware of what we actually do. And I think that it's kind of good to sometimes bring some awareness of, the different types of jobs that kind of hold a system together. So I really appreciate you being able to give us the opportunity to just kind of share our perspective on this, especially during this, crisis. So I've been a respiratory therapist for a few years now, and I absolutely love my job. I think that, it's a pleasure to be able to come into to an area where obviously most of the patients we see and we take care of are very critical patients that require us to be able to be there for them. And a lot of them obviously are, when they have respiratory issues, they can't breathe. And, as you know very well, respiratory therapists do help people breathe when they can't breathe for themselves. And I think that that's one of the most important key points. And then things that we do, we basically utilize all our knowledge that we have gained throughout all our years of learning and also studying to be able to basically utilize our tools. And that involves multiple different kinds of machines and, invasive, non-invasive equipment to be able to kind of bring those patients to a stable point. Again, this critical time, we are actually just kind of trying to prepare as much as we can for the worst to come. If that is the case, we are here for the community. And obviously we are here to support our doctors and be a team player in all of this crisis.
Miguel, being here means that you're a leader, that you're an advocate for your specialty, that you're an advocate for your life choice and for the work that you currently do. And one thing that kind of I actually commented on last week on a meme that I got posted on Facebook is that they showed this flag from Iwo Jima, resembles these military soldiers that were upholding the flag of the United States. And this battle flag was being held by nurses, physicians, and I don't remember what was the other third person that was holding it up. But I mentioned, I think we're forgetting about one of the crucial people that is helping us to keep this flag steady upright, which are the respiratory therapists. And which is funny, Miguel, a few days later, CDoc MD, he actually did his own sketch of the respiratory therapists rushing in behind to be part of the team. And you have never been forgotten. But I think, as you said, this is the moment that we need to use to put the message out there on letting people know exactly what you guys do. So, Miguel, in simple words for the general public and for our listeners, medical and non-medical, tell us, what is the job that a respiratory therapist do? And first of all, let's start, what's your education? And then what exactly do you specialize on doing?
Yeah. So obviously, respiratory therapists can serve in any platform of the medical field, right? We have respiratory therapists that can be outpatient, right? Outpatient care, pulmonary function technicians as well. So they basically do PFTs. So there are many different platforms in which the respiratory therapist can play a big role in our medical field. But obviously, certainly is the most important, obviously, is critical care, right? To just put it in layman's terms, I guess, we are those frontline people that basically step into every critical care situation. So when doctors such as yourself need aid in being able to not only help diagnose or just prepare for a critical situation, we are the first, if not one of the only individuals that is at bedside with the patient, being able to look at them. And in different areas of facilities as well, we are oftentimes the ones that have to intubate those patients and then place them on a mechanical ventilator so that we can breathe for them. So we do the most invasive thing to the least invasive things. That means that if you walk through a critical care unit, you will most likely see a respiratory therapist taking care of those ventilators along with the doctors and being able to pass down information that's going to be helpful for doctors to be able to make critical decisions for those patients that are requiring life-saving measures. And then obviously, to the least of least invasive, we provide aerosolized medications for those crucial asthmatics, COPD patients, and those who are coming in struggling to breathe. And so oftentimes we're there, to be able to help them diagnose and treat those patients quickly enough so they don't get to a more critical standpoint. So obviously, different things we do. And myself, I have a bachelor's degree in cardiopulmonary sciences, and I have just taken some boards like adult critical care ICU exams and MPS for ARC, which basically means pediatric exams and things like that. And a lot of our therapists are very specialized in many different areas.
Don't go short on your credentials. Tell us more about your credentials so people realize the amount of training that you guys have, because, nurse practitioners talk about what it's like to go through training. PAs talk about to see what's their training. And for foreign listeners, the international medical graduates that don't know how the system in America works, so everybody has a certain degree of training. I want you to tell me about your credentials. So you have bachelor's degrees on cardiopulmonary sciences.
That is correct. So just to elaborate a little bit, I think that sometimes we're often compared a lot with nursing, but yet in our world of just medical, right? Oftentimes, some people lack the understanding of how much education we really have. But whether you go through a bachelor's degree program or whether you go through initially just an associate's degree program, you have to go through 2 years of prerequisites, right? Of just taking all the anatomy and physiology and all the other classes that would basically prepare you to be able to enter this type of competitive program. So just like nursing, if they were to go to any community college or something like that, they have to take 2 years of prereqs and then 2 years of the actual nursing program and then move ahead to get a bachelor's degree. So oftentimes respiratory therapists will have 6 years of education just with that. And on top of it, we take board certifications, which, the ACCS, the Adult Critical Care exams, that basically gives us more in-depth in education and how we can function in the critical care area, basically learning a lot of hemodynamics and things that we kind of brush off in school, but now it's like more in-depth and, scenario-based criteria. And, we learn all these type of things so that we can be basically experts into it, in quotations, right? We are the frontliners there. We're with the patient. We're being able to read graphics on these ventilators and just watch our patients breathe on those machines and determine whether the right modes of ventilations are appropriate for that patient or are not appropriate for those type of patients. So these breathing machines are not just like a toy. You know, they're not just basically put them on and titrate some numbers and you're good. It requires a specialty. It requires you to be able to visualize what you're seeing and now make it basically the lungs for that patient. You know, you have to tweak a couple of things and make sure that the way the patient is breathing is exactly how it should breathe in that machine. And I think that's one of the most essential things that we do.
And you cover the whole spectrum of life, from neonates to small pediatric, teenagers, young adults, mature adults, seniors, all the way from the beginning of life, from a baby that cannot breathe when they're born, all the way to the very last minutes of your life, correct?
I agree. Yeah, I think that's one of the most exciting things about my job. I think that we have to basically specialize in all ages. It doesn't matter whether it is a newborn to the oldest person we receive. We have to be able to take care of all kinds of breathing issues. So in my personal experience, I've literally worked with cardiac babies and adult cardiac issues and adult asthmatics to pediatric asthmatics. So, in critical care areas, obviously when we respond to any of those situations, whether it is a 4-year-old or whether it is a 80-year-old. And we're there to help any kind of patient, that no matter their age and no matter their circumstances, for sure.
Miguel, one thing that I've noticed through my career is that for the most part, you guys, I feel that are not very well recognized across the healthcare system. I don't think respiratory therapists get the credit that they deserve. And one thing I've seen is that most of the time you guys are really humble and kind of very pliable on interacting with healthcare providers in every setting. During the trauma situations, during the medical intubations, you're pretty quiet, but we don't really give you the importance that I think you guys deserve. And that's why I'm here today with you, Miguel, because I want to make everybody aware how essential are respiratory therapists in this crisis. And right now, as you said, Miguel, people are moving through the ventilator. They're getting intubated and you're analyzing the ventilator modes, you're adapting the vents, and you're pretty much running out of ventilatory options for these critical patients, right?
Yeah, that is correct. I think that, just to kind of piggyback right on that, I think that a lot of the respiratory therapists have the knowledge needed to be able to take care of all these critical care patients, but oftentimes they feel like they might need to just be in the back of shadows because they feel like they're, feeling this resistance from some of the medical practitioners that they partake with. So
why do you think that happens, Miguel, from your perspective, from your side?
If I were to describe it in my perspective, I think it's the lack of understanding. Again, just having this discussion with you in regards to how much education we really have and how much we really do know. Some people don't really appreciate that. And I think that we are often feeling like you described the picture of the doctors and nurses and scientists and, all of these people holding that flag together. And then here comes this respiratory therapist with the stethoscope flying away and just kind of rushing into the flag, right? So this is exactly how our lives really feel like every single day. We feel like we are the ones basically rushing in to save the day to a certain extent, right? Like we're just kind of pushing in there and we're bringing all the life-saving support systems and we aid that. We support it, we make it happen. And then at the end of the day, it's just like we were never there. So it's kind of like we come in and bring all the crazy things that are needed so that patients can stay alive. And oftentimes it's recognition goes somewhere else, which is perfectly fine. Sometimes I have described that all medical practitioners deserve the recognition for our hard work and how much we do. But certainly oftentimes respiratory therapists feel like they have to kind of stay in the shadows just because they feel like they're not appreciated. And that's kind of a sad thing to say and a sad thing to kind of bring to light, but it's the reality of things. I think that again, during this crisis and this pandemic, I think we are there. They need us. We are a vital part of this team and this body, and we're going to be here for the community. And we're definitely going to be there for our doctors and nurses and every other, medical practitioner that needs us. So our job is to be there and, obviously do our job to the best of our abilities. But certainly just, my personal humble opinion, I think that people just need to realize that we are there as experts and not just as someone who's going to plug in your machine and let it be it. We're there to, be an expert and treat these patients well.
Yes, as you said, Cardiopulmonary physiology is highly complex. I would say that is the most essential physiology. And to understand it, when it gets sick, it gets really more complicated because it's not only the lungs. When you call it respiratory therapy, you guys have to remember that the heart cannot beat without the lungs and vice versa. So one thing of sensing the urgency of how much we guys need you is when we have this impending crashing patient that is about to lose the airway that suddenly walks into the emergency department via EMS and everybody's like, call RT. And like for people probably don't know what means RT, but that means respiratory therapy. And we're like, rushing to find them, and you guys are intubating someone else in another place, and you call your backup, and we need to get the intubating tools and the ventilators or the BiPAP, and everybody's like, where's RT? We need them, because me as a doctor, without you guys in these critical patients, I cannot work. Let's talk about that. So you guys are crucial. You guys are essential. How many respiratory therapists do you think we have all across the United States to help during this crisis?
Yeah, so some of the studies, and this actually kind of caught me off guard, because sometimes you don't really think about how many of your bodies are out there, right? But some of the studies have shown that we probably have around 140 to 155,000. So when you look at it, as a big picture, there's not a whole lot of us, right? So it's kind of interesting to just kind of sit down and kind of look back to that, and it kind of shows a little bit of how much sometimes are there, but there's not that many of us, and how essential it can be also to have one of those respiratory therapists. Like I would share with you, and I have shared with you in the past, if you look at one respiratory therapist, we have multiple critical care patients in an ICU environment. One respiratory therapist can be responsible for maybe 5 to 7 ventilators at a time. And that's, if many of those patients are not, all of them are extremely critical. So like just to kind of balance back and forth between those patients is extremely difficult job to do. Just imagine like having to, again, like you explained, oftentimes it's not just one organ, right? Some changes that you make in the ventilator, oftentimes affects your hemodynamics and other organs as well. So we have to be very, very diligent, very careful in what type of things we follow. And yeah, doctors are there, and they're ultimately the decision makers, but our job is to be, aides and to be advocates for our patients. So sometimes when doctors are overwhelmed as well, and they don't know exactly, what kind of decisions they're making, we're there to kind of say, well, this may not be always the right decision, but, we don't mind playing that role as well as advocates.
I try to be very humble when it's about the cardiopulmonary function, and when you guys intervene and help us kind of rescue those hypoxic, hypercarbic patients, means low oxygen and high CO2, which is not a good situation. And you approach us and said, doctor, I have this patient, this mode, this much tidal volume, this much oxygen concentration, this is the rate, this is the mode that I'm managing the patient with. I think we should move ahead and do these little tweaks. And oh my God, for our lay people listeners, the task is remarkably complex. A minimal change in a respiratory rate might change your pH that could lead to a critical deterioration. And sometimes, I'm going to tell you the truth, more than once a respiratory therapist has saved my patients and has prevented me from making an error, or actually has picked up on a crucial potential flaw, like a leaking tube, a ruptured balloon on the endotracheal tube, a tension pneumothorax from positive pressure barotrauma. That might be redundant from barotrauma. But I think you guys have saved the patient and actually made me a better physician.
Thank you. Yeah.
In my personal experience, Miguel, I have been humbled by how much knowledge you guys have. And I think all of us need to understand that we're all part of this team and we work together, that we all have to be treated with respect. Sometimes I feel a little bit of that harshness on the interactions with our respiratory therapists. And tell us more about that, how you guys perceive that lack of appreciation that we got. I don't know, what's the feeling on your community? If you have people advocating for this issue, how do you approach this situation?
Yeah, no, I honestly, I just thank you, because again, I've never had any issues working with you. And I think this is one of the reasons why I really enjoyed this interaction. But just to bring some light into some of the stuff that, not just, myself as a practitioner, but sometimes, I'm sure across the United States, many of my colleagues may be going through this as well. And I think that there's this stigmatism, right? That we're just techs, we're quote unquote techs, and we're just kind of like going there and just basically bringing a machine, right? And that's all we do. But in reality, we do so much more than that. I have multiple instances and just basically like, stories of how oftentimes you're the one who walks into a room full of individuals who you quote unquote think they should know what they're doing, and with all these machines and things like that. And you're the one having to kind of basically like save the day, you know, bring in and act into a quick action of an emergency and re-push a trach into the patient's air, you know, things like that are very crucial to what the situation is taking place. And then once you basically have done that, one of the things that I have experienced, and this is a true story, that I, you know, just kind of like going through this process of saving a patient's life. Once you have done that, then egos come back up, and then they kind of push you to the side, and then you're no longer the hero, because, you know, they just kind of, their prize coming in, and it's like, I'm the top person, right? And I'm the one taking care of the situation, and you're being pushed to the side, and it's kind of like your job was not important, but yet you were the individual who actually came and did the right thing that needed to be done. So I think that's essentially what happens across the board. Sometimes, you know, from lack of knowledge, you'll see nurses or, you know, believing that they're somewhere up here, and then respiratory therapists are down here. And I'm like, oftentimes I feel like I may have to fight my way in to simply say, hey, we don't, you know, we're equal here. You know, we are team members. We work together. We were trying to do the same job to take care of our patients. And oftentimes we have the same education that you might have gone through, you know, and once again, we learn a lot of critical care, and we are essentially just learning and just trying our best to be able to be an aid for doctors and, you know, take care of our patients the correct way. So, yeah. So I think that's one of the things that we struggle with the most, that we get this backslash, like, you know, we're just considered as techs and uneducated people maybe. And it's just such a sad, false statement.
What is the largest society that rules over respiratory therapists in the United States?
Like as in like what? Like
college or association that gathers the board certified respiratory therapists across the United States. Like for me, it's the American Board of Emergency Medicine through the American College of Emergency Physicians. They kind of partner up and they stand behind us.
Yeah. So the AARC is basically the one that takes care of all our credentials and things like that. So they are the ones that oversee, you know, all respiratory therapists across the United States.
The American Academy of
Respiratory Care.
Respiratory Care. Fantastic. And so it's a formal association that has at least 155,000 respiratory therapists across the nation, right?
That is correct.
So I bet that right now, Miguel, you are listening through your professional associations, through your personal professional blogs, through your colleagues across the nation, through meetings, that this situation is bad. Right. What is your feeling and your objective, I call it non-dramatic opinion, on what we are really here dealing with in COVID-19 in 2020?
Yeah. So, you know, just I basically, in my humble opinion, I can say that times can be a little scary and uncertain, right? Because we're hearing a lot of different things. I think that it's important. Obviously, there's the news that kind of are just stating a certain, you know, factor. And then obviously you're working at your current facilities and you're seeing the things that are coming basically in and out of the hospital. So, and then you obviously see the things that, you know, our colleagues in New York and things are dealing with. But, you know, when you look at all that into a perspective, right, you follow the trend and you start seeing that, yes, even though we haven't quite hit this sort of peak that, you know, we've been expecting, you start seeing the trend of how we're kind of just peaking slowly up. And that's what brings the uncertainty, right? Because we're kind of facing this peak where there's this black cloud on the back. We don't know exactly what it looks like, and it could be a perfect storm, right? So just to kind of bring you into some light.
You're giving me goosebumps, by the way. I'm not joking.
Yeah, no, and it's very true. Obviously, you know, we know that this could be a really crucial moment, and it could be something that, you know, that we pray that it doesn't happen, right? Because it's not the situation we want as practitioners. And obviously, you know, for a fact that you don't want that as a doctor either, right? But certainly we have to prepare for it as if it were to be something that could come, right? So, you know, we see the things that are changing even within our facilities. Like, you know, many people may not even have heard this, but you probably would know, like, you know, our BiPAP non-invasive machines basically that are essentially to prevent intubation are now being set up to be converted into ventilators, just because we are expecting this maybe shortage of ventilators. So non-invasive machines are now, RTs are working with it to convert it into mechanical ventilation, basically invasive machines that will be able to ventilate more patients if needed to be, right? So those are the type of things that, you never thought that could possibly be there, but those are the type of things that we're expecting. And even sometimes bringing those old mechanical vents that I probably have, the only study with, and during school and never seen it because we never had the need to see it. But here we are maybe bringing some of those old ventilators back because we don't know what to expect. And if we needed them, they could be there to help.
I heard one of your female colleagues, we were chatting in the EDH, she says, so how we are holding up? I said, Dr. Osorio, believe it or not, we're dusting off and bringing back into life whatever ventilators we have available, even if they're old. That's how critical the potential situation could get. And those machines work phenomenally well. The only difference is that probably these ones, the modern stuff that probably break even more often, are more computerized, right?
That is correct. Yeah. So it's funny because, there are some of those machines coming in and it just kind of gives you nightmares, for the people that are graduating recently in this situation because they've never, had to really use those type of machines to a certain extent, but they learn so much about it because, they're great tools to learn. So don't be surprised. You may see some of the respiratory therapists out there functioning some of these machines that may look like not a ventilator at all, but they function just like one. It's essentially that. I mean, we're prepared to fight with pencils and sticks if we need to. And, oftentimes respiratory therapists are referred as MacGyvers, right? We're able to just build anything out of anything to just kind of make it happen. And you'll see that, so if I have something to tell the community, is definitely you have respiratory therapists out there
I saw a respiratory therapist that was coming up with this 4-way connector to make one vent work for people.
Yeah, certainly there are some ventilators, that we call them our trauma ventilators that could potentially do that. It's not, obviously you would know as well, it's not the most recommended thing that we could possibly do just because it plays a lot of factors in how this could properly work, right? Not everybody has the same kind of static compliance and, physiology or whatever. But, certainly if it came down to life-sustaining measures, I think that we would go into desperate times and utilize anything we have within our power. But yeah, one of those things is definitely being able to set up a machine and ventilate multiple patients all at once.
Miguel, and since you say so, we've been talking about ventilators, but the ventilator is not the ventilator. The ventilator has a circuit, it's connected to a tube, and you have the supplies to kind of suction and the solutions to clean, disinfect, the filters. There's so many things that play a role into the system of a ventilator. How are we doing on supplies? Because now we're talking about PPE. I don't know if it's the same shortage, but nobody talks about supplies for the ventilator system.
Yeah. Well, honestly, current facilities that we work in, we haven't quite heard much of having that sort of shortage yet. But for sure, when you think about things into perspective, right, obviously the more ventilators you get, the more supplies you'll need. And obviously, if supply and demand, right? If there are other areas of the United States that are actually requesting for those type of supplies too, I wouldn't be surprised if there's going to be a time where we may have the machines, but we also don't have the setups to be able to put them together, right? So hopefully it doesn't get to that point, but that's certainly a thought that, we may have them. But just like the same thought process we have, right? I have several conversations with multiple, practitioners we're getting all these ventilators, and how many do we have? And it's like the thought process and the question in the back of my mind is how many respiratory therapists do we actually have? Because oftentimes we can have 10,000 ventilators, right? But if you have only 2 respiratory therapists, how do we manage these ventilators, right?
How's the usual ratio? Because I know in the nursing world, there's always call-outs, there's always shortage. How does it work in the world of respiratory therapists? Are you guys, obviously very much like me, we're shift workers. Yeah. How does it work for you guys to avoid that need, to avoid that rush into that situation that there is not enough of us sometimes to care for patients?
Depending on which facility you're obviously working with, they follow certain criteria to kind of give you what we call a safe number of patients. So obviously to the least invasive amount of patients. So sometimes in the floors, when it's what we call floor care, floor therapy, respiratory therapists could be taking care of multiple patients just because we know that these are non-critical patients, right? We can go in there and just kind of provide them their breathing treatments, their essential IS, which is a Siemens spirometer, teach them how to, pulmonary function type thing, right? Just kind of inflate their lungs. So just really simple things. We can do that. without having to be too involved, and it's not a critical care patient. So we manage it by just basically essentially just doing a practice of calculating the amount of patients that we can see. So, some facilities will have one-to-one patient care. So this means that we are in that room for maybe approximately, if it's just regular breathing treatments, 10 to 15 minutes per patient or 20. And then we're teaching them how to take their medications and so on. Now, when we move on to the critical care phase or the critical care scenario in this type of environment, obviously it involves more critical thinking and it involves more bedside to patient care, right? So most of the therapists at my facility, and I can probably say across the country, will probably have, again, about 5 to 7 ventilators per RT.
Wow.
So that means that, and even those type of ratios, they're very harsh ratios. And I think that sometimes, those are one of the things that I constantly fight against with the ARC and the thought process of how we could consider this sometimes safe. I say that because, again, it's like, I'm also an instructor, and oftentimes we see the same ratio with the students, like nursing would have one-to-one nursing student, right? So they have a nurse and then they have a nursing student. But with respiratory, sometimes you'll see the instructors walk around with 6 students or 5 students, which is not always the best thing to have. But that's kind of like one of the things that how our practice and field works, and how I feel like, it plays into the bigger picture we have been discussing now, that they don't realize how important our job is, and therefore they overload us sometimes. But yet here we are playing a big part in critical care. So when we have those really sick patients and we have to take care of 5 to 7 really critical patients and manage these machines and help manage these machines, we as we do art lines,
Arterial lines means, for our listeners, those are punctures into the arteries to measure precise oxygenation and some other curves that kind of coordinate with the cardiopulmonary physiology that we analyze carefully and follow really closely when you're in critical condition. Not everybody gets an arterial line. You really are going down the drain if you need an R line, but the part of that you guys do, that I would say 99% of the time, not even the doctors are doing those.
Yeah. So we play a big role in that. We oftentimes, we intubate patients as well in our critical care areas, and even on the floors, we are part of the rapid response teams. And when those patients that we go to rapid response teams require not only, intubation, but any other critical, obviously, support, then we're there to do that. So we play a big role in many different situations, for sure.
The other day, I didn't know that one of your colleagues was walking around with an instructor, and we had a critical patient coming in, and I said, go ahead, give it a shot, because in a few weeks, the pandemic was kind of coming across the world from China towards Italy, etc. And I said, because in a few weeks, we're going to run out of physicians to be intubating people. And I think you guys are going to be ventilating people right and left. So go ahead and go for it. And the teacher, the supervising preceptor, said, I'm sorry, doctor, but he's just a student and he's not credentialed to intubate on his own quite yet. I said, I can do it though. But I think that keeping the skills fresh, not only practice with mannequins, but also doing the critical airway management, is an important skill that we all have to keep it refreshed, because when the moment comes, you gotta do it.
Yeah, that's for sure. And I think, that's another thing that people that may not know, like, when we go through school, we basically, we do multiple intubations and practice and learn the anatomy of intubation and all of that, and try to learn that skill. Obviously, you have to build upon it after that, but we obviously love to do, and we know that we can serve as those type of individuals that can that role as well. And, maybe you can be an advocate for a lot of those respiratory therapists down in the ER that would love to just be able to have those opportunities as well.
Absolutely. If you're working with me, you can have them all.
Oh, yeah, that's for sure.
Miguel, talking about COVID, let's get a little scientific here, but also to handle it in an easy way for our listeners. Why the corona? It is so harsh on the human body right now. What's causing to these lungs? What are we seeing?
Yeah. So I think that, from my understanding and what I've been kind of witnessing, is obviously just the harsh of what we call pneumonia, right? So a lot of people that understand the physiology of what happens with that, is basically this bug comes into the lungs and attacks these alveolus, and it fills them up with this fluid-like pus, right? And it's like, and basically your lungs are intended to basically be able to stretch open and take that air in and exchange the carbon dioxide, right? That happens when you breathe in and out. But in this case scenario, obviously, when you're when your lungs, your alveolus that are obviously there to kind of receive that oxygen are being filled with fluid and pus, like, they aren't able to stretch, right? So your lungs are now becoming stiff, is what we call it. The effects of static compliance, right? And this type of criteria, right, it becomes very critical to not only take care of the patient, but to help them oxygenate, which is ultimately the biggest thing that your lungs do, right? They oxygenate the entire body and every organ of your body. So if we can't ventilate these patients properly because their lungs cannot expand, so just think almost like a sponge, right? If the sponge is normal and there's no fluid in there, you can kind of squeeze it and it comes back to normal place. But if it's filled with fluid, then what do you think is going to happen? When you squeeze it, all that comes out is fluid, and sometimes that fluid falls into different areas of the body, and then it just becomes a redundant problem for what we're trying to do. So when we can't oxygenate, like you said, many other organ failures begin to happen because, again, every other organ revolves around oxygen. So if you're not oxygenating different organs, then here we are building more different issues. And I think that's the hardest part. So, when we have to do that, there's a lot of different things that we can try to do to almost aid that. But if the lungs are just stiff and if we can't ventilate them, unfortunately, there's not much we can do.
That was a fantastic explanation. Something that we have seen and that people are reporting is that day number 6 to day number 10 after the onset of the coronavirus infection could become the potentially most critical phase, in which this little virus is attacking these specific protein receptors on your lungs that have affinity for the little sucker. And when he gets there, he makes some significant inflammation, as you said, and then people are spinning down into a drain of significant respiratory distress that's why they call it the COVID SARS, SARDS. So the SARS is a respiratory virus that causes distress, but you go into SARDS and the patients have sometimes need to go in some very fancy ventilations methods to decrease the mismatch and kind of you start flipping the patient like a little arepa back and forth to kind of oxygenate them, hoping that you kind of recruit all those alveoli in the process, correct?
Yeah, that is correct. Yeah, so many people are familiar with rotoprone beds. That's essentially what they do. We're recruiting those different type of areas that may be underventilated, atelectatic areas, right? So yeah, and then obviously many of those respiratory therapists that are maybe listening, they know that we have this awesome modes of ventilation that we can utilize, such as the bi-level or what they call APRV. So those type of ventilation modes, not everybody is very familiar with it, but they work phenomenal with it.
They're not very familiar. And when I was in residency training, I would walk into the ICU and I would look at that patient and say, what the hell is going on there? I say, oh no, there's an APRV. I said, what? I never seen that in my life. And you start looking at this picture and you're like, oh my God.
Yeah. It's not a normal way to breathe, but certainly will pop some of those alveolus open that may need some recruitment, that's for sure. So yeah, so we know how to use that mode of ventilation very well. We love it. And especially my facility, I can personally say that our respiratory therapists are experts with that mode of ventilation, and we're there to help. So yeah.
What else can you tell us on behalf of your colleagues today?
Yeah. So I think that, just simply, I think that I'm speaking not only for myself, but for many of my colleagues. I think that, we just simply want to be able to feel a part of this big picture, right? To be able to feel a part of this big team. And I think that many of my colleagues deserve the respect and appreciation of their hard work in education. We are experts, we are not just techs, right? We're not techs and just bringing machines. We are experts in cardiopulmonary sciences. We know how to take care of critical care patients. So I've made statements before, just trust your respiratory therapist, seek help.
Your life might depend on it, literally.
Yeah. I mean, we're there to basically help you and help those recover from critical care situations, and, trust them, respect them, and give them the respect that they deserve. I think that they are there, and if you see them every single time, they're involved in the most critical situations. And oftentimes, believe it or not, they have seen a lot because they go to every critical care situation, and their experience is gold. It's gold, and it's needed, and especially in situations like this where most critical care patients that are going to be coming in, if we are expecting them, are going to be with respiratory issues.
Miguel, are you feeling afraid of going to work during the pandemic, especially you? caught in an ICU, let's say, full of COVID positive patients? How do you protect yourself? Are you concerned about your young wife, your young family? Do you stay awake at night before you go into your shift if you're in a COVID potential infected patient area?
Yeah, so I think that obviously, we are here for this, right? We, to a certain extent, we knew that like we take care of patients, and that's our goal, right? We come to work because we love to serve our community, and we love to be able to provide for our community in that aspect. So we're human, right? There's this certainty of fear to a certain extent, right? Where we often think, okay, what if we are the ones that catch it, right? But certainly, like, we're here to help our community, to be able to be supportive in this hard time. So if I have to say, like, I'm not afraid of my job. I think that I'm actually glad that this is my job, right? Because with all the patients that we receive and even those type of patients that could potentially get sick and critical, I'm just happy to be able to help, and I'm just happy to be able to be there for them. And I'm sure you share the same passion. You wouldn't be an ER doctor or any of those type of things if you didn't care about helping individuals. So like, even though we take precautions, right, we want to be able to wear the right PPE and all the type of things that are required for us to be in those critical situations. But when we come home, we, obviously take our clothes off and take precautions there as well. But certainly I would love to tell the community, we're basically here, right? We're here to support you. We're here to take care of you as a patient, if that's, or your family members, if that's what it comes down to. But, we're doing all we can in our precautions to be able to stay safe and take care of our patients.
Well, I'm going to ask for you, Miguel, when I get intubated after my COVID infection, because I need a passionate, aggressive, and knowledgeable respiratory therapist by my bed. Okay, just keep me sedated, right?
Listen, my friend, I hope it doesn't get to that point where we're losing doctors and nurses and everybody else from this situation. But I'll definitely make sure we give you a nice dose of propofol.
And not a 9.0 or a 9.5.
No, we're going to definitely give you the biggest one we can.
That's the size of the tube. Yeah. So we are hearing that doctors and nurses are dying, but we don't hear if any respiratory therapist has died this far during the pandemic in the United States.
Yeah, I'm not exactly sure if there's any facts of a respiratory therapist being exposed. I know that
probably exposed for sure, but probably dying from it. I don't. Are you guys probably more cautious than us doctors or nurses?
I would tell you honestly, like, we are. This, we are literally looking at the patient's face right there, like as we are if we have to intubate or anything. So we are probably the most, like, just as doctors, the most closest person to those individuals' faces. So the fear is always there, right? We take precautions, obviously, but we are exposed 100%, maybe 120% all the time. But certainly, I'm not exactly sure, what the statistics may say right now, how many of those people are actually, even sick. But for sure, we know we're getting exposed, and we just really hope it doesn't come down to us being sick as well. I mean, hopefully that's not the case. I'm
enjoying this interview like a little child. So before I wrap it up, I'm curious about something. I see that across the world, COVID patients are getting incinerated. They're not getting buried. What's the process that you are putting in place to manage these ventilators that were circulating these viral particles after a patient makes it out or not the ICU? And how are you disposing of the circuits, the filters, and the supplies in the management of these patients? How are you handling all that?
Yeah, so I think that, across the country, I'm sure they have different procedures and how they're doing this. But certainly I can just state in what I've seen some of our facilities. Obviously, there are different ways you can do this, right? But even just in the facts of even transporting patients, we're now placing HEPA filters, which basically are like really, really sophisticated filters that would capture this type of bacteria and not allow it to go into the air. So we put this type of filters in the exhalation ports, which is basically the exhalation port is where patients, when they take an exhalation, then it goes into that port.
When they breathe out, correct?
When they breathe out, it goes through that port. So we place those type of filters there so that it doesn't go into the atmosphere and then obviously potentially be infecting our own healthcare workers. But in regards to the cleaning process, we're tearing down these machines in the actual physical room, and we're basically trashing everything in those rooms And then some of the process that's been talked about and also that is being done is UV lighting those rooms with obviously those machines that just basically light up the entire room and just begin to kill bacteria. So those ventilators are staying within those rooms, and then basically killing all those bacteria within those rooms, and then being wiped down and then brought down to the dirty equipment department, and then they get again cleaned up again in a different manner and in a much efficient way, and then put back into the system. So that's essentially what we're doing to try to prevent the spread of the virus just by being in those machines. So that's important.
Well, it's been an hour of your time. Thank you for taking an hour of your time, Miguel, to have a humble chat here with me. As I said, my platform is dedicated for foreign and international medical graduates. I don't think in my country I really got to feel the critical necessity as I do have it right now in the United States, and the close relation that I have to have with my respiratory therapist. For me, going to work is all about having fun and staying humble. I think I don't have an ego to defend or an ego to protect. I think we're fighting a fight of egos is what we're dealing with. And then I think it's a moment for you guys to step up and feel recognized across the nation, across the world for the hard work and the tough hours that you're putting in, all those years of schooling and education that you have put into. And from the bottom of my heart and on behalf of every single provider in our facility and hopefully across the world, I thank you for what you do, for stepping up and for caring for our patients, because what you do matters and it makes a difference in the outcome of these people and their families. So thank you for what you do, and thank you for being here, Miguel.
Yeah, no, thank you so much for the opportunity that, just to be able to bring some things to light. So certainly we are grateful to have physicians that, can just basically, be humble about the situation and know that we're all here as a team. And that's essentially what our role is to be a big family, to be a big part of this big body, right? We're all a body, and we're here. We're here to help our community, to help our doctors, to help, our nurses and everybody at bedside to take care of our patients. So
Miguel, I'm going to ask you for a favor. If we overcome this crisis, I want to meet up with you probably in 6 months to a year and kind of share the experiences of what it's going to be like dealing with these patients and this disease, because I think this is just the beginning. As you had said earlier on, I think we're starting to see more cases, and the curve is steeping up. Yeah. So your expertise will be very much appreciated on getting the message out there. And as I said, thank you so much, and thank you for helping us to make, as they say, America great again.
Yeah, I certainly appreciate it, Dr. Osorio. So it's been a pleasure. You're a great friend of mine, and we'll certainly be working together at some point soon. So we're here to support one another. So thank you once again.
Gracias.